So today we're really excited to have Dr. Alfy Olufade speak to us about high yield return to play decisions. Before we get on too far, I want to make sure that we know that next week we are going to review general review of injections by Walter Sussman, and that'll be 8:30, like we have for each of these lectures. The goals of these lectures are to adjunct your home program's educational content, to provide fellows with direct access to educational experiences with AMSSM members, and at times invited guest experts, also to assist you in your CAQ prep. Remember to mute your device's microphones and turn off your video. We have questions. You can submit through the chat function and we'll get through them towards the end. Or if you need to interrupt, please kind of raise your hand on the chat function. The moderator will ask the questions during the Q&A, and we will also probably have some questions that we're going to throw out to you that you can answer on a polling device. And also, we please ask that you complete the evaluation at the end of the lecture. We really, really want your input. We try really hard to get great topics and speakers to help educate us on the latest and greatest of what's going on and keep everyone up to date. There are lots of ways that you can go about doing this, one of which is go to amsssm.org under the Education, the Fellow Online Lecture Series, and there's a form there. There's also a QR code that if you click on, take a picture of that now, you can go ahead and it'll take you right to that form. But remember, the primary goal of this lecture series is to assist in CAQ preparation. So I'm super excited tonight for Dr. Alfy Olufade to talk us through high yield return to play decisions. Dr. Olufade is an assistant professor in orthopedics at Emory School of Medicine. He's board certified in physical medicine and rehab, sports medicine, and interventional spine. Dr. Olufade received his undergraduate degree at Rutgers University in New Jersey and went on to attend the Robert Wood Johnson Medical School. He did his residency and postgraduate training at Temple University Hospital and Crozier Keystone Healthcare System in Pennsylvania and Philadelphia. Dr. Alfy practices sports medicine with a special interest in youth sports, active adult, regenerative medicine, orthobiologics such as PRP, bone marrow aspiration concentration, lipoaspirate injections, and his approach is focused on the non-surgical treatment of sports and orthopedic injuries, including ultrasound and fluoroscopic guided procedures. He treats adolescents and adults, and his patients range from middle school students to professional athletes. He's involved in research in regenerative medicine and has presented at numerous regional national conferences. He is well known on this topic because he served as the director of soccer medicine at Emory Sports Medicine, physician for several athletic teams and organizations, including U.S. Soccer Physician Network, Atlanta Hawks, Atlanta Dream, Atlanta Vibe, College Park Skyhawks, Emory University, local high schools, and he's also actively involved in AMSSM, where he's on multiple committees in a leadership role. He's also active in national and local media. So I am very excited to introduce Dr. Alfy Olufade to discuss high-yield topics in the training room. Go ahead and switch over, Alfy, if you'd like.
All right, good. Good evening, all. I'd like to thank the Fellowship Online Education Committee to help me, for inviting me to speak. This is a topic that's near and dear to my heart, and so is dear to every single one of us taught as a sports medicine physician. Oftentimes, we get asked the questions about when we see athletes, the first question they always ask is, when can I return to play? This is the same question they ask us in middle school, high school, collegiate, as well as a professional team. Most recently, Kevin Durant during the Olympics sustained a calf injury. And during the point prior to the Olympics starting, he was walking around doing everything, but he still was not playing. So one of the questions is, why was he not playing with a calf injury? He was able to walk around, shoot a little bit, and travel with the team. What else is wrong? Is he hurt? Is there other injuries going on? So this is a question that we mostly ask. My background ranges through a wide range of sports, but one of my passion is in soccer medicine, which is called football to the rest of the world. We call it soccer. So when you think about the top injuries, even though it's player specific, the top injuries in soccer includes hamstring, than groin injuries, ankle sprains, quadriceps, as well as calf. Depending on what position you play, this rates of injuries would be a little bit different. So as you imagine, a goalie probably would not have a high incidence of hamstring injury versus an outfielder or offensive guy. So it ranges, but in totality, this is how common it is. A few months ago, UEFA is the European League. And one of the things we know in the world of soccer and football to others is they probably have one of the best players in the world. A lot of money has been put in. And the money that's been put in is not just to the players, it's also been put in into taking care of these athletes. As a result of that, they have a very robust medical as well as rehabilitation, as well as injury prevention program. So suffice to say, a lot of people will say that UEFA group is probably one of the top in the world. When they did an epidemiological study that assessed the injury rates for about 15 years or so, they found that hamstring, groin, ankle ligament injuries, quadricep muscle, calf muscle injury, as well as knee MCL sprains is one of the top injuries. And it actually gives them about 50% absentee from the players that choose to play. In addition to that, when we think about this, oftentimes some of the injuries might not be severe. So if it's not severe, it's not so much of a big deal. If you think about mild injuries, usually that would get better within less than 7 days. Oftentimes, they tend to be more like capsulitis and mild issues that will get better in 7 days. When you think about the moderate severity ones, usually that takes about 7 to 28 days to get better. While the severe ones last longer than that, it takes about a month or greater. The moderate ones, the issue is if you have an injury, which you have a high frequency of it, and you have moderate severity of it, that tends to put us in a situation where an athlete will be out for a longer period of time. The biggest question is, what's the return to play protocol or criteria for returning athletes with all these injuries that they might have? So when that 14-year-old asks you, or when that collegiate player asks you, Doc, when can I return to play with my AC sprain? Or when can I return to play with my hamstring sprain? What are the answers we give them? More importantly, we know we have to do better, because one big thing is the re-injury rate for a lot of these injuries it kind of spans a range of about 10, 15%, so sometimes as high as 60%. So there's something that we're doing wrong. It's not well, and we need to fix that in order to put our players in better position. So obviously, I don't expect every single one of you to read some of the bullets on the table. I kind of put the things that I wanted to kind of care about more. This is the AFO study highlighting the top injuries that were mentioned. Once again, the problem with these injuries is high frequency, moderate severity, so you will put patients out for a longer period of time. My goal is to kind of highlight a little bit of some of the return to play protocols and criteria that we have for these injuries. So when you look at this EFS study, I think this is a bit much. I think an average ankle sprain in most places would take longer than 7 days. Groin injury would take longer than 8 days. But because of the contrast at hand, because of if they don't play, they could lose the position. Just because of the high stake of the injuries, this EFS studies, the number of days that people are out is a lot smaller compared to other injuries that you will see around. So the question now becomes, when you identify the index injury as the first injury that occurs, and you identify the re-injury that's as high as 15 to 20% to as much as 60%, the bigger issue is the re-injury rates actually takes a player out for longer than the actual index injury that they sustained. Meaning if they sustain an hamstring strain the first time and it lasts 3 weeks, if they re-injure it, it actually adds another 3 or 4 days, in some cases longer than that, compared to the initial injury that they have. So this paradigm of treatment, it's not working. So a few years ago, the concept is, can we have a decision-making return to play protocol, and how do we go about that? And this is important because when you look at the first two, it highlights and talks about the tissue health and the tissue stressors. The tissue health is just the history, the physical examination, kind of seeing how uncomfortable that injury is. When you look at the tissue stressors, that's more of like what kind of position did you play? Are the leg dominant or not? Do they have the ability to have a full range of motion? Can they protect themselves? And just like anything else, are they mentally and psychologically ready to kind of get back to doing everything? Those are the risk assessments that you have to compare to the risk tolerance, meaning what time of the year is it, the pressure to kind of return to playing sports, is there any conflict of interest? If the first two, the tissue health and the tissue stressors, if the risk is much lower than the tolerance, which is the step 3, then the return to play is permitted. But if the case is the otherwise, then it's not permitted. And I'll touch the base, I'll elaborate on this later on during this presentation. So when we do return to play, oftentimes you want to check for clinical assessments. You want to make sure that athletes are able to be able to functionally return to their sports. Psychological readiness is very important. As we know, 1 out of 3 folks that have ACL surgery, for example, are not able to return to the pre-injury level that they had. And some of that boils down to just not feeling right and the knee not feeling good, them just not feeling psychologically ready. There are other host of different things, including biokinetic, biological timing, which I'm going to stress on, as well as team integration. When is it appropriate to kind of put them back with the team? So the first concept that I'm going to introduce, or one of my take-home messages during this conversation, is biological healing versus criteria-based. So let's look, for example, lower extremity injuries. If you have an ACL sprain, or if you have an hamstring injury, or you have an ankle sprain, oftentimes the return protocol will be, can they work on a straight line? Can they do the lateral movements? Can they do some cutting as well as sport-specific agility? Can they mirror the practice? How about return to practice? And can they return to play? Based on the conversation that I've had with you earlier about the re-injury rate of hamstring injury being as high as 30% when somebody goes back within the 1 season, as well as high as 25% sometimes during the first week, I will admit, or I will confess to us that the criteria base that we're using, it's not working as well. One of my proposals today is to kind of discuss and highlight a little bit of more of a biological healing and talk about a little bit about what is the science behind the healing and regeneration versus just having them go through this criteria, which quite frankly has failed us in the past few decades. So let's start talking about some of the injuries with high frequency and moderate severity. The first thing we'll talk about is MCL. What we know about MCL is the distal aspect is a little bit more stronger compared to the proximal aspects. We know that the tendency of healing is actually a little bit more difficult in the insertions versus the mid substance, which is a little bit easier to heal. We know the vascularization is better proximally versus distally. And as a result of that, somebody that suffers a proximal MCL sprain is more likely to get better versus that somebody that suffered a distal one. We have 3 different gradients of it: grade 1, grade 2, and grade 3. So what is the return to play on this? How quick and how fast should they return to play? From a Pearl standpoint, when we see ACL injuries, especially one of the concerns is to be able to identify Stenner's lesion, where that's more of a tear as well as retraction of the superficial MCL. And as a result of that, the superficial MCL distally kind of retracts to the level of the pes enserine. Usually when you have that, that's a situation where they would not necessarily heal well by themselves. So be aware and vigilant when you have an MCL injury, looking, assessing for Stenner's lesion, because that's something that will result into a poor return to play protocol. With that said, if it's grade 1, they will get better within 2 to 4 weeks, grade 2, 4 to 6 weeks, and grade 3, 6 weeks or more, depending on the severity. So what are some of the things that you could walk him through from the criteria-based standpoint to say it's okay to return? Early mobilization is important, increasing the load as well as doing some strengthening, transitioning to the bike to kind of make sure they're not stiff inside, doing some cross-training jogging, having them doing some agility drills, introducing some ball in the case of a soccer or football player, and depending on what other sports they might be playing, introducing, for example, this baseball, just kind of hitting the ball and things like that, and eventually returning to full training. So we'll talk about meniscus a little bit. Depending on what sport you look at, meniscus is very common just because of function in the knee. 8% of soccer players actually have meniscus injury. Partial meniscectomy allows them to return to play faster versus if you repair. So oftentimes, depending on age, especially in the professional world, more than likely they will want to do a meniscectomy in order to kind of return. Some will argue this is a little bit early, but in the European studies, definitely people with meniscus repair or meniscus surgery, meniscectomy, and the medial meniscus are able to return about 5 weeks versus the lateral meniscus, which takes them a little bit longer if you do a meniscectomy. It's important to assess the ACL during the point of this because the ones that fail, usually they fail because the ACL sometimes is also compromised. So let's compare a little bit more details about meniscectomy versus meniscus repair. If you have a lateral meniscus, usually that's a little bit more difficult to kind of return to or outcome if you have a meniscus meniscectomy, a shaving of it, of the lateral meniscus versus the medial. The NFL studies suggest that if you have the meniscus cut or shaved, you actually have about a 1.5 less years in the league, as well as about 15 less games that you play as a result of this. In addition, when you look at the reoperation rates, if you have meniscectomy, you're less likely to have reoperation versus if you have a repair. And that's why oftentimes, especially in the older population, they tend to go more with a meniscectomy as opposed to a meniscus repair. How about the meniscus repair? If you repair a lateral meniscus, they tend to do better versus a medial meniscus. The return to play for this is about 6 to 8 months. So when they ask you that question after meniscus repair, that's the answer we could give them. It suffices, and we should know that it's only about 90%, 9 out of 10 folks that return back to the previous play after a meniscus repair, and not everyone does return. So we do a lot of imaging studies, we do a lot of ultrasounds, we do a lot of MRIs. How does ultrasound affect return to play? When you have this bedside ultrasound, what role does it play? So when we talk about imaging study, this is an MRI grading where you could grade from grade 0 to grade 3. Point of distinction, grade 0 is more like you just have edema, but you don't have any myofibril detachment, you don't have any increased signal or defect, and you don't have any full retraction. Grade 1 has a little bit of edema, but you start having some of the myofibril of the muscles attached. Grade 2 involves edema, the detachment of the myofibril of the muscles, but you start having some signal changes with the connective tissue, while grade 3 results into a retraction or failure of the musculature. Elstran et al. Did a study, and this was for the hamstring, suggesting that on an average, if you have a grade 0, it takes about 6 days to return to play, versus grade 1, it takes 17, versus grade 2, it takes about 22 days. But if you have a total rupture, it takes about 73 days to get better. So what about the ultrasound? One of the more common classifications that's used is this BAMIC one, which is the British Athletic Muscle Injury Classification, grading it from grade 1 to 4. A couple of distinctions. If it's A, usually it's more myofascia versus if it's B, usually it's more myotendons. If it's A, usually it's less than 10% cross-sectional area and less than 5 centimeters of length. Versus if it's grade 2, usually the cross-sectional area increases from about 10 to 50%, and the length increases from about 5 to 15. Versus if it's grade 3, usually you have a greater than 50% cross-sectional area and greater than 15 centimeters in length. So we're going to refer to this later on, understanding some of this grading from an MRI standpoint, as well as from an ultrasound standpoint. And sometimes it could be used in prognosticating how soon or how fast they will return to play. So let's talk a little bit about muscle injuries. Hamstring, sometimes it takes about 12 to 18% of football players, as in soccer, but it's a very high in American football as well. Sticking with the soccer and the adductor injuries, it's about 5%. quadriceps is about 5%, and calf injuries is about 5 to 13%, depending on what literature you read. These numbers might be small, maybe not too much, but what's more important is the reoccurrence of it and how often, as much as 50% of times, athletes are not able to return to play because of these injuries. So let's delve into a couple of this, highlighting some of the points. So if you have a grade 1 hamstring, grade 1 or 2, usually between 1 to 2 weeks, or 1 to 3 weeks, or 2 to 3 weeks to be exact, you get better. I've highlighted the issue with the criteria-based protocol that we mentioned, because 25% will re-injure it within the first week, and about 30% will re-injure it during that season. One of the goals is to kind of decrease the risk of a risk factor, and we know previous hamstring injury, just like we know previous ankle injury, is one of the strongest risk factors. A quick plug-in for FIFA 11, which has been shown to decrease the injury rate of lower extremity in soccer players by about 50%. What we know is during this high-speed running, that's when most of this hamstring injury occurs. And oftentimes with this injury, the hamstring is in the lengthened state, the hip is flexed, and the knee is extended. And that's kind of what predisposes the hamstring to being torn. So what is the accurate way to return athletes to play? How do we know when they are ready, when they have these injuries? Because we just said that some of the criteria does not work. These are the host of the different studies that has used pain, strength, flexibility, functional performance, medical clearance to see if they return. But I mentioned again, we have failed. And so the question that this author posed is it time to consider natural healing over this criteria-based? So if you have to give a framework of the how long does it take, this is a study that was done to kind of give us a general idea, suggesting that if it's grade 1, using the median, grade 1 is about 21 days versus grade 2. Grade 1 is about 14 days versus grade 2 is 19 days versus grade 3, which is 59 days. But look at the re-injury rates at the last tab. You can see the re-injury rates, according to this study, is about 16%. That's just not enough. So a few guys came up with this hamstring return to play protocol, suggesting the criteria in grain are the ones should be used. Not having pain at rest, not having pain with activities, checking on the flexibility of the hamstring, making sure they're psychologically ready, as well as doing some performance testing. Those are the grain. The ones that we're not so sure of, number of games or friendlies completed, number of full training that are completed. And I'll get back to that because there's another study that kind of said the opposite of that training, but we'll get to that in a minute. What the neuromuscular functioning is, and MRI is one thing that I want to highlight. So just to make it clear, MRI and the pictures and what you see at this point should not be used to determine if somebody should return back to sports. It could be used as a framework in terms of an average of when they might get back, but it's not should be used in the decision-making. One of the major omissions, like I mentioned, is it doesn't highlight how many games is played. It doesn't highlight return to fitness. It doesn't mention do they complete the rehab fully. And it doesn't mention that they should be 100% recovered in fitness as well as skill testing before they return. So this is one of the more important slides. So one of my proposals, or one of the author's proposal is when you have an hamstring injury, you should actually sit them out for at least a month to decrease the risk of re-injury. So when you look at this particular muscle study, degeneration and inflammation after a muscle injury goes on for at least about 3 weeks. You don't have regeneration until about 4 weeks, and you have scar tissue formation that occurs as well too. So if the degeneration and inflammation is still going on for 3 weeks, it's probably not a wise idea to kind of return them back to playing sports, because that's one of the reasons why they have a high re-injury rate. So to kind of summarize and finish up the hamstring, so questions we have to ask ourselves, and one of the more recommended algorithm is this. Have they followed the natural healing for grade 1 or 2? Has it been 4 weeks before we consider return to play? If the answer to that is no, then we should not return him to play. If the answer is yes, the question is that they passed those other tests as well too for readiness. If they pass the test, like the battery of the things that we mentioned, including flexibility, being pain-free, then we should return them. But if there's not passed those tests and readiness, then we probably should not return them. I mentioned this very briefly to a few colleagues the last time. One of the issues is we don't have a perfect return to play protocol as well, too. There was a study that was done highlighting that if you do a lengthening protocol versus a conventional treatment, it's just a different types of rehabbing of hamstring. The risk of re-injury is almost half, 28 days for the folks that, actually in terms of getting back soon, 28 days for the folks that did the L protocol versus 51 days for the ones that did the conventional, suggesting that we have to know the right type of rehabilitation to do as well too. And there's a few other things, including the L protocol, as well as the Askell's H test that's been shown to kind of decrease the amount of re-injuries when athletes return to sports. So this is a couple of few slides just to highlight. If it's grade 1 or 2, wait for 4 weeks. We don't have any conclusive return to play process. Understand that the natural healing is important, and please respect that. One of the questions is, can MRI still be helpful? There's a small percentage of people after the return that do have this new scar tissue that forms. And the question that this was posed during the study is, can this be one of the folks that actually have re-injuries? I think the jury is still out on this, but I think just because we do a lot of imaging studies to diagnose, there's a goal or the hope that we could identify some of the return to play protocol using imaging studies, but we don't know enough yet. So let's move on to quadriceps injury. That occurs in about 5% of soccer players. It's 1 out of 5 soft tissue injuries that occurs. If it's from a kicking injury, usually it affects the rectus femoris, versus if it's more of a contusion or direct injury, that tends to affect more of the vastus intermedialis, lateralis, as well as medialis. If it's more of a kicking incident, usually that tends to affect the septum, which is one of the issues that takes a longer period of time to heal. So when you look at the MRI, what this illustrates on the top is a full avulsion injury of the rectus femoris tendon proximally. When you look at the bottom one, it shows a little bit more of a muscle injury to the rectus femoris as well as vastus lateralis. You see that on the axial view as well on the sagittal view at the bottom right of the image. Some of the risk factors are discussed over here, but the healing process is another thing that I want to highlight. If this is not healing well, I think it's important to respect the healing process, wait for about 4 weeks, depending on the severity of the injury. A couple of studies, a couple of tests that could be done, isokinetic muscle testing, Thomas test, as well as flexibility test matters. If the cross-sectional injury is greater than 15% or longer than 13%, similar to the British ultrasound classification, they are more likely to have grade 3 and grade 4, and they're more likely to take a longer time to recover. If they have a severe proximal tear, like I highlighted in the first MRI that I showed you, the injury risk is very, very high. 2 out of 3 are more likely to reoccur. So in those scenarios, it's postulated or suggested that maybe surgery should be done. So when you have that collegiate athlete with that proximal tendon tear of the rectus femoris from kicking, if it's a full tear, maybe considering surgery a little bit earlier will kind of allow them to return back to the sport in 3 to 4 months. This is a little bit excessive, but I'll try to highlight a few points on it. So this is just a schematic for anterior thigh pain and leg pain. So starting from the left, if it's a contusion, if it's more of a Charlie horse type situation where they just have occasional pain and paresthesia, rehabilitation works. If it's more of a Morale-Lavelle lesion, if it's acute, it's important to aspirate and go on to rehabilitation. If it's chronic in nature and it's still symptomatic, it kind of makes sense for surgical evaluation. If it's myositis ossificans as well too, and it's symptomatic, then it's worthwhile to consider surgery. If it's an indirect injury, meaning from a kicking incident, there was no direct trauma, you want to assess for pain and palpable gap in between. You want to check for painful motion and movement and check for strength deficits. If the MRI confirms that, if it's the proximal rectus femoris, like I mentioned, if it's a partial tear, it's reasonable to consider rehabilitation. If it's a full tear, it makes sense to consider surgery. If it's a mid-substance injury, if there's a significant gap that's present, it probably makes sense to consider surgery due to the high reoccurrence of it. If it's more of a recurrence or it's chronic in nature, you want to assess if there's any retraction or scar tissue formation. If there's some scar tissue formation and retraction, but you're able to rehabilitate it, it makes sense to avoid surgery. But if they fail rehabilitation, then consider surgery. Lastly, but not the least, if it's the circular tendon that I showed on the first MRI, if it's acute, it makes sense to consider surgery if it's not a full tear. But if it's a full tear, surgery is probably recommended. So that's kind of more of just an algorithm or protocol to kind of consider for anterior thigh pain. So what time do you offer that basketball player that comes to you and say, oh, football player that got hit in front of the thigh? Usually if it's grade 1, usually they're able to get back better in about 12 days. If it's grade 2, about 22 days. Grade 3, about 6 to 7 days. But it's important to kind of see what the re-injury rate is there. And I think one of the questions that kind of still affects us is we don't have a universal way or universal algorithm to say, do X, Y, and Z. And if you do those, you're extremely less likely to return. The next couple of injuries that I'm going to explain, I think we've gotten a little bit better in terms of some protocols that are recommended. But for quad, we don't have any consensus that's agreed upon by everybody. So we're going to move on to adductor tendons. The adductor muscle and tendon, that tends to happen in multiple injuries in multiple sports. About 2 out of 3 acute adductor injuries actually happen from a non-contact injury. Even if it's grade 3, I've treated a few. I treated a rugby player, a professional rugby player a few months ago with grade 3 adductor injury, and they were able to return. It took them about 10 weeks. And we gave that presentation at AMSSM last year. My point is, even if it's grade 3, they could still get better without surgery. Contrast to the UEFA study, where they had grade 0 to 2, they actually returned in 14 days. I reiterate, that's just a little bit too early to return. And that's kind of oftentimes why people have a lot of injury and re-injuries due to this. This is some of the exercises that are often done to kind of rehabilitate adductor muscle. It's called a Copenhagen hip exercises. And it's just listed here and documented here for our information. I don't feel I need to kind of go through that, but you have it as a resource. So one of the questions is, how can we predict returns to sports or return to play? This was a study done by Andreas Cerner. And what he said is, if you palpate the proximal tendon and you have pain, or you have a defect that's present, the return to sports is a lot longer, ranging between 4 to 11 weeks, versus if they don't have pain around that proximal area and they don't have a defect or gap, they're more likely to return in 2 to 4 weeks. So I think this is some of the pearls and tools that we use in sideline. If somebody's strained their adductors and you don't feel that proximal tenderness and you don't feel that gap, and you're able to have an ultrasound sideline to kind of take a look, you know this is a less severe one. They might not be able to return that week, but you have an inclination that, let's sit out a week or 2, maybe in 3 weeks or so, you're more likely to return versus otherwise if they have the gap as well as the tenderness on the medial aspect. Another proposal that I think is more hands-on with this adductor injury is the study that was done by the same group, Andreas Cerner. So what he proposed is, first, you have to make sure they're clinically pain-free before they return to sports. The second is you have to make sure they're able to participate in sports training before they return to sports. In this particular study, 75% deemed themselves to be pain-free at rest. It's only about 62% that deemed themselves pain-free or were able to complete sports training. And regardless of that, 93% of them did return. The good news is for the folks that did not have pain before they returned, it's actually a 5% re-injury rates that they had versus the folks that didn't have pain-free. They were 20 times or 20% more return to re-injury rate, meaning the folks that were pain-free are 4 times less likely to have a re-injury versus the folks that did not complete that. The folks that completed the sports training, they were still twice less likely to have their re-injury. So for adductor tendon, adductor muscle injuries, making sure they're pain-free, making sure they're able to complete the sports training decreases the risk of re-injury that they will have. If it's grade 3, understanding that it will be a longer, it might take up to 2 months to get better. So what about gender differences? Myself and a couple of colleagues at Emory did a study a couple of years ago to see that is there any reason why women are more likely to have ACL injuries and knee sprains versus men are more likely to have hip adductor issues. What we saw with the cohort that we did was men were more likely to have hip flexor weakness and adductor weakness, and women were more likely to have hip abductor weakness and hip extensor weakness, suggesting that one of the reasons why men and maybe soccer players in general are more prone to having injuries of the adductors is because of the weakness. There's a couple of follow-up studies that will probably take place to see if we strengthen some of these hip adductors, are they more likely to have these injuries as the season progresses? And those are some of the things that we look forward to presenting in the future. What I mentioned earlier was more about acute adductor injury. There was a consensus statement that kind of addressed more of a chronic groin injury. And this is another take-home message for adductor. I think it's important to measure the strength. Interestingly enough, the experts didn't reach a consensus in being pain-free. It also mentioned that you should have performance training or performance tests, and also as sport-specific tests. If you have those 3, they should feel more comfortable returning an athlete to sports. What stands out very clearly again in red is that imaging studies should not be used as a means of return to play because it just does not prognosticate return to play very well. So imaging can act as a guide to diagnose and maybe give you a framework, but imaging study and what you see over there should not determine if you return an athlete back or you should not return him. So we're going to move on to calf injuries as we round up this last few slides. Calf injuries are very common. It tends to affect more older patients or older athletes. Majority of them actually happen through non-contact in soccer. The injury rate or injury rate is about 13%. And this particular study that I had cited at the bottom suggested that if you have a muscle injury, usually those gets better a little bit faster versus if you have a myotendinous injury. So this is schematic on the left, highlighting what the soleus looks like versus the middle one highlighting what the gastroc looks like. The SA is more of the soleus aponeurosis. The FGA is more of the free gastroc aponeurosis. And the Achilles tendon is the one at the very bottom. When you look to the middle image, the GA is the gastroc aponeurosis, and the next one is the free gastroc aponeurosis. The reason why this matters is depending on what injury you have. So I remember, several years ago, I always thought calf injury was always tennis leg. But it's suffice to say that's not necessarily the case because there's a wide range of injuries that will happen from tennis leg. So this particular imaging studies that I'm going to show in a few minutes highlight the differences. And now the differences on ultrasound can give us different return to play in terms of, is it going to be 2 weeks for them to get better versus is it going to take 4 weeks to get better? So when you look at A, the A is only affecting the gastroc muscles. The arrow is more of the aponeurosis, and it's not being affected. When you look at type 2A, it's affecting the muscle itself, but it's starting to affect the aponeurosis. But the amount of soft tissue that it affects is less than 50%. Versus when you look at the 2B, usually it affects the gastroc, it affects the aponeurosis, but it also affects greater than 50% of the muscle. When you compare it to type 3 and type 4, usually this is when you have the free gastroc aponeurosis involvements, and these are the ones that ends up being more severe. I repeat, not all tennis legs are the same, right? So the type 1 that I mentioned will react or treat very differently versus a type 3 and type 4. So the devil is in the details in terms of what they look like. Pedret et al. Did a study in 2019, and this was a study of multiple sports, including soccer, basketball, and a few other sports. And what it showed is even in the athletes, type A, usually they will get better in 10 to 15 days, versus type 4, it could take about 50 days to get better. Even in the non-athlete, the statement remains the same. So when we have a calf injury, I think it's extremely important. The ultrasound can help us prognosticate better. It doesn't tell you absolutely saying, depending on what it looks like, they should return or not, but it gives us an idea of when they should return or not. So what about soleus? The soleus is a little bit differentiated into different sections. The AF is the anterior aspect, the PF is the posterior, the MA is the medial aponeurosis, the CT is the central tendon, and the LA is the lateral aponeurosis. And what the study suggests is the central tendon one are the most severe cases, and those are the ones that actually will last a lot longer, and not necessarily 2 to 3 weeks like we initially thought, but it could actually take as much as 6 to 7 weeks in order to get better. So what this suggests is usually the calf injuries that are really bad that will have aponeurosis injury, they tend to occur with running versus other type of mechanisms. What it also shows to the right with the chart is the folks that have greater than 50% injury to the aponeurosis, they're more likely to take longer for them to get better versus the one that doesn't. So just a couple more slides on the calf injuries. I think this is just a few of the take home. This is more from an MRI standpoint versus the ultrasound that I mentioned earlier. If it's grade 1, usually they will get better between a week or so. If it's grade 0, will get better within a week. If it's grade 1, 17 days versus 24 versus 48. Between gastroc and soleus, if you separate those injuries out, the soleus tends to take a little bit longer to get better. The soleus tends to be more of a subtle chronic condition that comes in, versus a gastroc injury tends to be more of a sudden onset that will happen. And those are kind of the summary that I just mentioned earlier. Soleus takes longer. Central tendon of the soleus, as well as free aponeurosis, takes longer in order for you to get better. And this is some of the rehabilitation protocol that's been recommended and it's been shown to be quite efficacious. So I think this is one of the take-home for calf injuries, highlighting the vast distinction of a 2-week injury that could get better with the soleus myofascial versus something that has aponeurotic issue on the soleus that could take 4 to 5 weeks versus a medial gastroc injury with rupture of the myotendinous junction that could take much longer and take as long as 7 weeks to get better. Lastly, but not the least, we mentioned about ankle sprains. It's very common. If you have one injury, you're more likely or twice more likely to have that injury the following year. We know that because we don't rehab this very well. As a result of that, you have some mechanical issues as well as sensory issues that takes place, and that's what results into reoccurrence of the injury. Sadly enough, because of how fast we get our athletes to return to sports, about 40% of them will develop chronic ankle instability after they have a lateral ankle sprain. Loss could take about 40 days. So the question is, can we do better? Can we get them a little bit back a little bit earlier? These are some of the risk factors as well as some prevention. Some of this has not been 100% proven, but this is some of the things that we do recommend our athletes to kind of do in order to decrease injury and re-injury of it. So a lot of times when we see our athletes, we'll identify for pain, we'll take a look at swelling, we'll look at range of motion, we'll check on the strength. And this is some of the things that a lot of us do daily. But the point I'm trying to make on this slide is not all of this has actually been proven to be useful in return to play. For example, if you have a swollen ankle, the swelling of the ankle, it might not necessarily be from the ankle sprain. It could be from a chondromalacia or some other issues, and that's not specific to the ankle sprain that they have. These are some of the ways that you could measure this, and there was a consensus statement that was done highlighting this type of different mechanisms to kind of monitor ankle sprain when it happens. But what should we really be using in returning to play? There was this acronym called PASS, which you assess the pain during sports participation and pain over 24 hours. You check for ankle range of motion as well as strength. You check for that perception of confidence and that psychological readiness, making sure they're okay to return to things. You check for proprioception as well as balance, as well as go through the agility test. What the consensus is from this international group is this is actually what we should be using to define or determine if somebody should return back to playing sports, and not the extensive list that we usually use before. So far, I've been able to highlight to you guys that we do have a lot of injuries that occur. The ones with high frequency and moderate severity are very important to treat. Even when you have that second injury, they're actually more likely to stand out or be out of sports for a longer period of time versus the first injury that they have. We know that it's important to respect the natural healing, because oftentimes one of the reasons why we have this re-injury rate that is as high as 30 to 60% is we don't respect the natural healing. We know that we don't have a lot of consensus statements in terms of our return to play protocol, but we have some ideas and guidelines as well as some expert opinions in terms of ways to decrease these injuries and safely return these athletes back to sports. So myself and a few colleagues a few months ago looked into the idea if orthobiologics actually can be helpful in increasing the return to play, just like we said we want to respect the natural healing. Depending on what side you belong in the orthobiologic debate, we all know that there's a little bit of trying to instill a newer process of healing, a more natural process of healing. And the whole idea is orthobiologic can be helpful. So we look at 951 studies, and eventually we got about 75 studies. 62 of them were able to identify orthobiologics, specifically PRP, to return to play, versus 13 of them that looked at the surgical literature of PRP, surgery, and return to play. To kind of summarize it, we often get there's not a lot of randomized controlled study that shows that PRP works or it helps with return to play. The studies that were highlighted in green confirms or suggest that PRP actually does help increase or improve return to play, meaning it allows the athlete to get back to playing their sports faster. However, the studies in gray suggest that it didn't necessarily suggest that that was positive and that PRP does help in return to play. So what this particular study shows, or what our conclusion is, for what we were able to gather, for UCL, it takes about 8.6 weeks to get better to return to play. For hamstring injuries, it takes about 6.7. Various muscle injuries takes about 4.4. Interestingly enough, when you go back to that biological healing, giving it 4 weeks to kind of have regeneration, it does fit that mold. MCL, it takes about 10 weeks to recover. And patella tendon, depending on the severity, 11.5. Obviously, this is when you group foot and ankle, that's a huge classification. But this summer study suggests that there's actually some benefit to having orthobiologics in increasing return to play. The study was not without some issues. 14 studies, like I mentioned earlier, in general, I mentioned the randomized control study, but when you look at the retrospective study and cohort studies as well, too, in general, 14 studies showed superior outcomes. 4 of them suggested that the control studies were actually better, while 11 of them suggested there were no difference. The issue is the devil is in the details. As we all know, rehabilitation is important. We're still kind of trying to get better with the rehabilitation and orthobiologics, we definitely need to do a little bit better in terms of return to play protocol with the different injuries that we have. Only 11 studies out of the ones that we saw, 16.3, actually defined what the return to sports is, and only about 12% of them give the criteria to return to sports. Lastly, a couple of slides. One more thing is, if somebody is cleared, this particular study suggested that the more training sessions that they actually have 7% less likelihood of re-injuring themselves. If somebody goes back to playing, the first game that they return to playing, they actually have an 87% increased risk of injury with their first match that they return to versus the other ones to go. And a couple of training and other things such as this different warm-up and agility drills are some of the things that you could do to decrease those injuries. So I'll round up by saying rehabilitation is important. I think it's important to kind of understand the rehabilitation process and pay attention to it. When we look at this schematic that I got, it's important to kind of take a look at this whole process, but understand there's a lot more involved. Making sure they have good examination, making sure psychologically they're ready, making sure in the hamstring example that I'm giving over here, make sure you do the proper examination in the hamstring, the Askelling's H test, to see that they're good to return. Making sure they're able to do this functional drills before clearing them to return to sports. Making sure we respect the biology of waiting some time in order for them to get better in the mild to moderate conditions. Because if we don't, we're setting our athletes up for failure and re-injury. In conclusion, there's a high frequency of injuries with prolonged absence due to sports injuries. The muscle injuries makes up at least about 50% of them. We don't have a great consensus statement in terms of returning them, but we know we have a high recurrence. Biological natural healing, leaning on the studies that we have so far, taking a look at the consensus statements, are some of the way to get this better, but there's still a lot to learn and a lot to figure out. So I've been asked to kind of talk about two quick questions, and I'm happy to take questions after that. So the first question is a linebacker at the local high school that sustained an AC joint sprain. The injury occurred about a week ago, and the examination reveals tenderness and palpation of the acromioclavicular joints. The examination is consistent with AC joint pain with resistive shoulder adduction. The athlete is not able to return to full range of motion. So the question presents, what is the tissue health? The tissue health, just because of the way this is set up, I could take some points, but maybe for the sake of time, I will kind of answer some of what I had in mind, and I'm happy to kind of get into the discussion a little bit later. The tissue health obviously is poor. It's still an acute injury. The athlete is not able to return to play. As a result of that, they're not going to be able to play the role as a linebacker. So when you look at the tissue health and you look at the stressor, it's extremely high versus the risk tolerance that we mentioned earlier. It doesn't make sense to clear this athlete to sports or to return because they can't even protect themselves. So it would make sense for them not to return to play. The second question is a basketball player at a local high school who sustained a knee injury after a layup. According to her, she landed funny in the court, and she went to your office after an MRI obviously was completed, because oftentimes, depending on where you practice, some of your patients will come in with MRI. Which of these following conditions would you clear the athlete to return to play? So the options include patellar tendinopathy, knee chondromalacia, a stenosis lesion, as well as fat pad impingement. So we have a pool going on. If you guys want to kind of answer some of those, just take a shot at it, and we could answer some of those questions, or I could kind of get into the comments after I stop sharing my slides. To kind of put some clarity on this, I think is actually, the more question is actually, which one would you not clear the athletes? So I think there was a typo on that. And I think when I look at what people have down, so maybe I'll give it a minute. If you actually kind of clarify which one of these injuries would you not clear the athletes to return to sports? Andy, if you don't mind, is there a way to kind of put that back? So it makes sense. It's Stenner's lesion, because Stenner's lesion is the one that, it's more oftentimes doesn't heal by itself. It's more of a surgical evaluation that's needed. You could argue that patellar tendinopathy, even if you see it on MRI, it does not mean it's symptomatic. Oftentimes, as young as people might be, they might have chondromalacia on MRI. Obviously, the devil is in the details. So my point is that you could see it on MRI, but they might not be symptomatic. But Stenner's lesion absolutely is the one that you probably should not return, because that's just something that has to be treated. And so Stenner's lesion is probably the one that I wouldn't clear. So this is a little bit of some of my way of reaching me. And I have a host of references that are listed here. I will stop sharing my slide and happy to take some questions.
There was a question. What is the risk tolerance in question 1?
I'm sorry?
What is the risk tolerance in question 1?
The risk tolerance is, if you think about this, they don't have, for example, early in the season, it might be early, so it's not like there's a playoff that's coming in or something major going on. If it's like a contract year or something like that, that's a little bit different. This is a high school player, not a collegiate person, not somebody that's going to go into professionals, not somebody that's earning millions of dollars or multi-millions of dollars. So if it's a high school player, they still have a lot of pain. They don't have a lot of risk. They don't have a lot of things at stake right now. You will argue that the risk of the tissue, the risk of lack of being able to actually perform the role is extremely higher versus not, you're not getting a contract, you're not doing all that stuff. It's not like a playoff. So that risk is higher than the tolerance. And that's kind of why you wouldn't return that athlete to sports.
I really like that summary you even actually at the beginning you did, because I think that all return to play questions come down to risk tolerance. And also, just because they're a high school athlete, they might be looking for a college scholarship. They might be going to a showcase or something. And I take care of a lot of young kids, and I do talk to them about, the risk benefit of, your tissue just isn't ready for that. And you might make it through that showcase and you might get that scholarship, but now you have a higher risk of having greater injury. So I think, looking at the severity of the injury, the nature of the tissue injury, the expected recovery and all that plays into it, but also really making sure that they're psychologically ready. That the research on the number of practices before returning to play, decreasing the injury risk, is great. I kind of want to put that in a poster on my wall, because so many kids, in fact, I had a conversation with a athletic trainer today that said he wanted to not have this football player go to practice today for his concussion clearance, because he'd rather give him another 2 days and then just put him in the game. And I was like, well, no, put him in a practice setting. So I think it's important to kind of to get that mental aptitude of going back to play before you're into a competitive setting. So,
I agree 100%.
Are there any other questions from the audience? I think you did a really nice job of the overview of the muscle injuries. My only question for you is, do you use ultrasound a lot in your office when you see like a calf strain or a quad strain? Do you use it in the first visit, or do you wait, and kind of see how they're doing?
Several years ago, I did not use it as much, but when I've seen in the past couple of years, I tend to use the ultrasound for every single muscle injury, because it just allows me to differentiate, classify better, and allow me to counsel the athlete a little bit better. And sometimes tells me how aggressive I want to treat it versus not treating it. So yes, for most muscle injuries now, I use the ultrasound.
I think the education of the athlete really helps support our decision making and gets them on board with us. So I agree with that. Thank you so much for this overview. It was great, and good luck to everybody. And thanks again.
Thank you.